It's 10 o'clock at night. A clinician from the home treatment team arrives, stepping through the front door to evaluate an older adult in the middle of an acute mental health crisis. The clinician is there to make one stark, binary decision. Can this patient be safely managed at home tonight, or do they require immediate hospital admission? This graphic maps out the clinical framework for making that call. In the upper left, we see the absolute rule for older adult care. Past age 70, the default hypothesis must always be organic illness, not psychopathology. Diagnosing a psychiatric disorder before actively ruling out physical drivers, like delirium or a severe infection, leads directly to catastrophic medical errors. Treating a hidden physical emergency with standard psychiatric assumptions actively endangers the patient's life right there at the front door. Clinicians check 3 life-threatening dangers. First, dementia with Lewy bodies. Standard antipsychotics cause a 54% rate of fatal reactions. Second, iatrogenic harm. Interacting prescriptions often drive the crisis. Third, suicide in older men. High lethality and intent, frequently masked by profound denial. These 3 specific dangers prove that jumping to a psychiatric intervention without a thorough physical clearance is the highest risk path a clinician can take. To safely assess the patient, the clinician works through an 8-stage algorithm, systematically filtering physical reality against psychiatric assumption, starting with depression. They look past stated sadness to filter for hidden physical drivers, checking for severe dehydration or that masked male suicide risk. When transitioning to patients presenting with confusion, this diagram shows the primary tool used to separate dementia and depression from an acute crisis, the fluctuation rule. If the confusion came on acutely and their attention fluctuates, it signals delirium. This 3D pyramid outlines the required response, a tiered organic workup starting with a baseline 4AT screen and moving up through mandatory blood panels. Correctly isolating a sudden delirium from a slow-moving dementia dictates the treatment path. A delirious patient requires an acute medical admission for an infection or metabolic issue, rather than a psychiatric label. For psychosis, we rely on this diagnostic funnel. We only reach late-life psychosis by systematically excluding delirium and Lewy body disease first. Prescribing antipsychotics without checking this middle layer for hallucinations or motor signs risks a fatal reaction. Then there is the challenge of severe physical agitation, a patient pacing restlessly, demonstrating an uncontrollable compulsion to keep moving. The critical discriminator here involves mapping the symptom timeline against the medication timeline. If the pacing aligns with an increased antipsychotic dose, it isn't worsening dementia. It is a drug-induced condition called akathisia. Mistaking akathisia for behavioral agitation leads clinicians to prescribe more of the exact drug that is actively poisoning the patient. There is also the shut-down presentation. The patient is mute, completely immobile, and actively refusing all food and fluids. This diagnostic card identifies catatonia as the likely driver behind acute withdrawal, requiring a lorazepam challenge to confirm. The warning triangle highlights the extreme risk of adding an antipsychotic. Doing so can trigger fatal neuroleptic malignant syndrome. Broadening the lens to the patient's bedside table, the crisis is frequently chemically induced through polypharmacy and a severe anticholinergic burden. In these severe states, the complex web of medications meant to stabilize the patient is frequently the exact mechanism of their physical collapse. Shifting focus. At this stage, the clinician must shift their diagnostic focus entirely away from the patient's symptoms and evaluate the severe physical and mental exhaustion of the primary carer. This table highlights the systemic rule of older adult care. The system is the patient. Total carer collapse is a primary, independent driver for hospital admission. When home containment fails and an organic workup is required, the clinician authorizes the admission using this Mental Health Act flowchart. Section 2 is the legally honest frame for fluctuating diagnoses requiring physical assessment, whereas Section 3 requires a confirmed disorder. The threshold for admission is ultimately dictated by the limits of systemic containment and unresolved physical risk, rather than psychiatric severity alone. Back at the front door, the 8-stage assessment concludes. The decision to admit or treat at home is entirely grounded in medical safety. Older adult crisis care. It requires strict analytical rigor over protocol, relying on specific, auditable safety standards. True clinical mastery in these high-stakes environments is rarely found in assigning a new psychiatric diagnosis or adding a new pill. The ultimate medical intervention is deprescribing, carefully untangling and removing dangerous layers of medication. Resolving the crisis is achieved through the life-saving discipline of subtraction.